Hello everyone, welcome to our Health and Wellbeing Board on Thursday the 9th of December, 10 o'clock here at County Hall. Item 1 on the agenda is apologies for absence. Do we have any apologies?
Yes, apologies from Paula Mead, Kath McAvoy-Carr, Rick O'Farrell and Councillor Simpson.
I can add apologies from Councillor Renner Thompson, and Councillor Sanderson is currently attending a meeting about Storm Marwyn regarding the north of the county, but he hopes he might be here at some point, but we'll see how that goes. Okay, thank you. Item 2, minutes of the previous minutes of the meeting of the Health and Wellbeing Board held on Thursday the 14th of October to be circulated. Can we confirm them as a true record? Yes. Confirmed. Thank you very much for that. Item 3, disclosures of interest. I'm looking at me, Councillor Patterson and Councillor Watson. Any disclosures of members' interests? No, that's great. Thank you very much. Well, no further ado, I go over to item 4, which is COVID inequalities, communities impact assessment. Now I've got, here we are. I've got the Phil Hunter is presenting on that, and I'm not sure if Phil is or not. Are you ready, Phil? I was just probably a little bit, I was a little bit premature there, really. So we've got this is a presentation. It's to receive an introduction to the COVID inequalities communities impact assessment, how that will be developed further, and how the council intends to use this to inform recovery plans. And Phil is just setting up now. And Phil, are you ready to rock and roll?
Yes.
Great, thank you very much.
And apologies for my tardiness, Chair. So this report presents an analysis of the impacts of COVID-19, how the pandemic has affected residents, communities and businesses across Northumberland. And there's a covering report, and the detail of that is set out at Appendix A. Chair, this is a first draft. It's an ongoing area of work which will be refreshed and added to as new and more up-to-date information becomes available. Partners from the board and partners beyond the board may want to consider whether an inequalities impact assessment of their own area would be helpful to inform future planning and contribute to a richer picture of this issue. Sorry, Chair, I'm just slightly out of breath.
Yeah, it's all right. I started you very, very quick, didn't I?
Yes. If I may just take a moment. Okay. So, from a council perspective, we intend to use this analysis to inform policy and decision making moving forward as part of our recovery process, and particularly to shape our approach to tackling health inequalities which exist across the county. And we think that this work will also help to shape our conversations with regional partners as well as government. We know that the COVID pandemic has had profound impacts on individuals, families, communities and businesses across the county, and it's still very much with us. Obviously, I wrote this report before or just as the new Omicron variant was starting to emerge. So this remains a very dynamic situation, and it's by its nature, understanding the impacts of this will be a dynamic piece of work. First and foremost, we know there have been immediate impacts on health and wellbeing resulting directly from coronavirus, and I'll come back to that when I touch on some of the slides. Alongside the immediate health impacts, there have of course been wider social and economic impacts from COVID through restrictions in economic activity, obviously, limits on social interaction, interruption to education and constraints on community life. I think it's a really important point that pre-COVID we all know and knew that there were inequalities between the most and least disadvantaged areas and groups in Northumberland, and the pandemic will have exacerbated some of these inequalities, although it's too early to be certain about the long-term trends there. I think it's also important to note as part of this work that there were also some unexpected short-term positive benefits. In particular, we all saw and I think experienced a reduction in vehicle emissions as people had to work from home. There were less cars on the road, less traffic, fresh air encouraged more people to get out and about and enjoy the benefits of walking and cycling in the local areas. So it's important that we also identify and seek to build on some of those unexpected positive impacts, as well as addressing the more serious negative impacts. As the communities continue to recover from the pandemic, the Council has committed to working with all partners to reduce health inequalities in our communities. And as I say, we want to develop this impact analysis work further and use that to shape our approach to tackling health inequalities, as well as feeding into the joint health and wellbeing strategy. In terms of next steps, we intend to share a refined version of this work with communities, because it's really important that we gather their perceptions of how this is impacting on them. It's not just a sort of top-down look at the numbers and the trends. We want to ask communities how they have coped and how they are coping as we move further into recovery. So we're going to go out and do that engagement exercise with communities. Chair, I'm not intending to go through all 29 slides today, because that would probably take up almost all of your meeting. The information is there in the slide pack, and I say that this is very much, as I say, this is very much a work in progress. But I think it's useful just to point to a few salient slides in the pack. If I just... No, I don't think I've got this working. Perhaps Leslie could help me with this slide. All right. I've obviously jinxed it, sorry.
Just seeing if anyone can help at all.
If you wouldn't mind clicking to slide 1, the first slide. Oh, here we go. I've got it there. Sorry. So just on this slide, just want to highlight the structure and really open it up for some feedback from partners and members of the board in terms of, are we focusing in on the right areas? Our focus is on looking at the COVID response and inequalities first and foremost, understanding the pre-COVID picture in terms of equalities, looking at children's health profile, because there's a lot of concern obviously on the impact that COVID has had on children and young people's development and health and well-being, and then looking at those wider determinants around the economy, jobs, income, impact on poverty, housing, environment, education and children's services, and finally community safety. I'll just flip down. I think it's important to pause on this slide, Chair, the pre-COVID position, because it is important to think about the backdrop to all of this. As we moved into the COVID pandemic in early 2019, Northumberland continued to show a high concentration of deprivation, and that's as measured by the index of multiple deprivation. We know that that was concentrated in the southeast of the county, with many of the neighbourhoods defined amongst the most deprived 10, 20 or 30% in the county. And important again to point out that within this part of the county, the southeast, there are also neighbourhoods that are amongst the least deprived too. And deprivation is not confined to the southeast. We've got significant areas of disadvantage further up the coast around New Biggin and Berwick upon Tweed, as well as southwest of the county in Haltwhistle. And it's also worth highlighting those smaller pockets of deprivation in parts of the county that would generally be considered overall to be relatively affluent, including in Hexham, Amble and Alnwick. And all of this just reinforces the point that the picture of inequalities does not follow neat geographical boundaries, and that we had entrenched probably almost generational inequalities going into COVID. So that remains a huge challenge for us, and we think the early evidence shows that some of those inequalities will have been exacerbated by COVID. I think just wanted to highlight the COVID response and inequalities. I think nationally the evidence indicates a higher rate of deaths involving COVID in the more deprived areas of England, and the gaps between the most and least deprived areas for this measure widened as the pandemic progressed. I'm not an expert in this, I'm sure Liz could say a lot more about that. Locally, evidence indicates a link between higher rates of deaths involving COVID and deprivation in the county. Although I would say the pattern is less even than national trends, suggesting that there are other factors influencing COVID-related deaths beyond deprivation. I think we're drawn in a lot of national research in terms of our headlines on COVID and inequalities, because, as I say, data still emerging at a local level, but national research suggests a widening of pre-existing inequalities in mental health and education, increased income inequalities, despite the increase in universal credit and the furlough schemes that were put in place and supported people to deal with the income aspects of COVID. We saw wages decrease, particularly in the north during the pandemic. People aged 16 to 25 were over twice as likely as older employees to lose their jobs. So a real sense that young people, really bore the brunt of certainly the economic factors around COVID. And food insecurity, we think, affected something like 4 million households with children, and that was during from March to August 2020. So some big headlines in terms of the national research. Just touching on the next slide on the vaccination. Overall, Northumberland, as we know, as you've been updated, had one of the highest rates of vaccination take-up nationally, and there appears to be a link between lower vaccine take-up and deprivation, although the pattern appears to be flatter here in Northumberland than in other measures. I just wanted to say something quickly about mental health. Of course, we know, you know, as health and wellbeing partners, that there has been an impact on mental health and general wellbeing. And actually, I'm sure we've all felt that to some extent during the past 18 months. Really interesting piece of research, Government's Mental Health and Wellbeing Surveillance Report, which has been updated throughout the pandemic, was last updated in July 2021, and that presents some emerging and high-level summary findings from a range of UK studies of the mental health and wellbeing of children and young people in relation to coronavirus. Some key findings from that revealed multiple population measures revealed deteriorations in mental health and wellbeing between March and May 2020, and that was followed by a period of improvement from July and stabilising at levels comparable to before the pandemic between August and September in 2020. The data from that research indicated the proportion of adults aged 18 and over reporting a clinically significant level of psychological distress increased from something like 20% in 2019 to 29.5% in April 2020, so a significant jump. That fell back again to 20% by September 2020. So that period of recovery hasn't been observed in all studies, in particular one looking at depression and another looking at older adults aged over 52. So I suppose what that's saying is that for a lot of people, as the restrictions and lockdowns were eased and they were better able to cope, that there was a significant recovery in mental health, but not for everyone. And I think the key task for us as we move ahead with this work will be to get a clearer profile of what that mental health and wellbeing picture looks like on the ground in communities in Northumberland, and a better sense of what are the longer term impacts. Just going to move, Chair, to highlight a few issues around economic recovery and poverty. In purely economic terms, we're seeing a recovery across the sectors that were impacted. The shape of that recovery varies, obviously, depending on which sectors we're looking at. For some of them, they've bounced back pretty robustly, as soon as the restrictions were lifted. But overall, the latest key indicators show employment increasing slightly and unemployment continuing to fall. Claimants of unemployment benefits in general are about 25% less than the same time last year, which is positive. Economic inactivity rates slightly creeping up, we think indicating increasing numbers of people opting to take early retirement or people who are on long-term sickness. So as the lockdown restrictions gradually eased from spring through summer, we've also seen average weekly earnings rising steadily, and they are now above the immediate pre-COVID period. So that, I think, for the economy broadly looks positive. But we do know that there are inflationary pressures that are impacting, most notably in energy costs. I think we're all seeing that in our bills and general costs of living, and that will, we know, impact on households across the county. So we are, and we need to track that emerging picture and understand the full extent of whether any of that is being mitigated by wage increases. And the background to this is that child poverty remains a challenge, Chair, nationally, regionally and locally. We had seen an increasing trend in child poverty over the past 5 years across the region, and that's still with us, and that is a long-term challenge. So even as the economic situation improves, we need to keep a real focus on the impact on child poverty and the various interventions that we can make to alleviate that. It is interesting to note that whilst most of the food referrals that were handled by our Communities Together hub during the COVID lockdowns, most of those were clustered in the county's most deprived, lowest super output areas, as we call them, round about the southeast of the county. But that chart there, Chair, shows small clusters of demand in less deprived areas, and that might be explained in part by people who were clinically extremely vulnerable, requesting emergency food supply. We also know that the people accessing food support were doing so outside the Northumberland Communities Together hub or other council services, so this data forms only part of that picture, and we want to add to our understanding of the food referrals in the broadest sense as we move forward with this work. Just very quickly, we do know that the Citizens Advice Bureau experienced significantly increased demand for its advice services during the pandemic. The patterns in terms of the presenting issues, for example, debt, benefits, employment, etc., they remained relatively stable, but it's worth pointing out a slightly significant increase in people presenting with problems on energy costs, and we know that that's something that could very much increase due to the sharp energy price costs that are being experienced now. Chair, I'm going to stop there because I said I wasn't going to speak to all of these slides, and I'm slightly in danger of doing that. I just wanted to pick out a few key highlights for you, and I think I've done that. But I wanted to finish on some positive trends because I suppose there were things that really came to the fore during the lockdowns that we'd want to retain and build on. For example, that strong sense of community spirit and resilience and neighbours helping one another. That, of course, was always there, but really came to the fore during the lockdown periods. And, of course, in the past week or so, we've seen that again in the way communities have responded to Storm Arwen. We also know that people rediscovered the value of their local spaces, as places to go and walk and cycle and get a wellbeing boost. And this mobility data suggests, if I've understood it clearly, that although normal journeys have started to recover, people travelling to work and to go shopping and so on, so they've started to recover to pre-pandemic levels and trends. But most interestingly, the data suggests that as we recover from COVID, residents and visitors want to visit our parks and open spaces now more than ever, with data suggesting journeys to parks are almost 100% up from pre-pandemic levels. So I think it's important just to highlight some of those trends, those positive trends, so that we can understand how we build on those. So I will stop there, Chair. The report is recommending the board to consider and comment on the COVID impacts analysis and the supporting document in Appendix A, consider how partners and communities can contribute to a broader assessment, and agree to receive regular updates to this work.
Okay, thank you very much. Very detailed report, and I recommend, if you haven't had a chance to look at it, to take it home and do have really digest on that. We'll be invited to comment on this, and I noticed that Councillor Watson wished to comment, and I'll invite people after that.
Yeah, thank you. I agree. It was an excellent report. Read it through and understood it, and I think it's really good. I have 2 or 3 questions though. I'm often asked what the definition is of poverty, inequalities, and deprivation, and I actually struggle to answer them questions. I don't know what are the official designations of those 3 terms. And although we refer to them constantly in this document, we don't actually explain what they are. And I don't know how I can answer those questions. What is our definition of poverty, etc. The second one is I'm trying to figure out what the link between deprivation and vaccination is. Because even if you are deprived, you are still entitled to a vaccination. It's still there. It's in the... So why would it be any different? Wherever you are. And then I didn't understand your slide, why the determinants poverty. I really looked at that and I just couldn't figure out what that was telling me. I couldn't link it to any area. I don't know what the 1 minus and the 10 minus is. I couldn't get it. So those are my three comments.
Okay. I think they're valid comments, and I think there's more work to be done with this work in the slides, just to kind of demystify some of the data. I'll admit I sometimes struggle with some of it myself, so I think we'll take that away and do some work. To your questions on poverty and deprivation, I think we just need to explain that a little bit better in the slide pack in this work too. It can often get very technical. It's all sort of measures around multiple deprivation indices. It's measured across a range of things in terms of income, employment, educational outcomes, quality of housing, quality of environment, and a few other factors, and that all gets fed into an index to give us a picture of where the most deprived neighbourhoods are. But it can get very technical, and that probably needs a better explanation in the work.
You obviously look at things on your own area, but I've got deprived areas in Amble which have been accepted for a long time, but we've got none in Hadston, and I can't actually see the difference in what Hadston has got that Amble hasn't got, and I can just never figure that out.
Yeah, I think it's a really good point, and I suppose one of the things for anyone looking at deprivation and poverty is that it's often hidden. And it's not obvious, when you drive through. In some areas it is obvious, but for other areas you drive through and it's hidden because it's income deprivation, it's about poorer educational outcomes, it's about lower life expectancy, and that's not always obvious as you're driving from area to area. But yes, I think we can do more in these slides to just sort of explain some of that and demystify some of that. And I don't know the answer to the question on the link between vaccine take-up and deprivation, and I'm looking at my colleague Liz. Perhaps you might want to comment on that. Hopefully that's not a curveball I'm throwing you.
No, I don't think so. I mean, I think there is a general link between access to and uptake of healthcare between our more deprived and least deprived areas, and there are a number of reasons for that. It could be because of the working conditions that don't allow them to take time off easily to access healthcare. It could be around health literacy, that actually they don't understand the importance because we haven't explained it to them in a way which they understand. So there are multiple reasons why that happens, and it doesn't just happen in the context of vaccination. It happens across a number of other areas as well. But when you, in terms of inequalities and what inequalities are, we're really talking about systematic differences within the county, between geographical areas, between different communities, between different age groups, in how they access services, and also in terms of outcomes, be those, education, income, or any other aspect of society. That's really what we're talking about in terms of inequalities. I think that the thing that I wanted to just raise as part of this discussion was around recovery, because I think in terms of responding to the pandemic, there's quite a lot of science behind that. But in terms of recovery, there isn't a huge amount of science. So we have to look at recovery experience in terms of sort of earthquakes or floodings or hurricanes, to get some idea about the things that we need to focus on. And interestingly, the King's Fund did some work looking at recovery in the context of health and social care, and came up with some quite four distinct areas where we need to focus our activity. I think the important one for me was around community resilience, and how community resilience is going to be really key for us moving forward. But actually we can't achieve community resilience if we're leaving some communities behind. So as part of our recovery process, we really need to focus on those communities that are experiencing inequalities at the moment, because they are actually key to having more resilient communities in the future, so that if we have another challenge, those communities are able to cope better the next time around. I think this is a bit of a work in progress, and certainly it's something that we can use as a baseline, but also use to map recovery going forward, and just check in with ourselves about how successful we are in terms of that recovery process.
Okay, thanks for that. Yes. Can you press your button?
Right, sorry about that. Thanks for the report, which has a wealth of information, which I'm sure is of great use. But in that context, might I ask, as Liz said, this is a work in progress. Now it's on the agenda actually. How will the county use this information to try to alleviate the inequalities caused by COVID? And I think it's actually broader than that. It's not just the inequalities which have been exacerbated by COVID, but I think inequalities are endemic, within the county and the rest of the country. And it's how the county will, seek to use information such as this to plan to seek to reduce the inequalities. And I think the integrated care system, this is one of their 4 priorities. So it's just basically, this is work in progress, and appreciate the tremendous efforts in producing this report. But how will the information be used by the county and by this board actually, to see what can be done to improve the lot of the many disadvantaged people in certain parts of the county?
I think it's a very big question, Chair. I think the short answer is that we, as we move forward with our strategies, not just for recovery, but as you say, more generally for tackling health inequalities and those broader inequalities, we will use this work to shape and inform how we prioritise that activity, how we prioritise our interventions and our policies to alleviate poverty and deprivation. One of the things we're looking at doing is early in the new year is pulling together a sort of partnership seminar to start to look at all of this in a little bit more detail. So I think when we do that, and hopefully partners around this room and beyond will be involved, we would look to have those conversations about how we can use this and other data and intelligence in an intelligent way. So I don't think I've answered all of your question, but it's a start.
Yes, clearly this sets the scene, in great detail, but it's the next step. in terms of making a difference, which is the next important one. And I think you mentioned reports back to
I think
this
Liz
committee.
wanted to come in on this as well.
Yeah, thank you. I mean, I think we've done this for three reasons, really. I think we recognised that we needed to establish a shared understanding of the ways in which COVID-19 has impacted and continues to impact on Northumberland and our communities. I think we wanted to provide an evidence base to inform our response to COVID over the short, medium and long term. So how is that going to inform our recovery plan? And then the other reason for doing it was really to highlight the disproportionate impact that COVID-19 has had on some of, actually the most marginalised and vulnerable groups in the county, so that we can actually focus attention on those particular groups. I think in terms of, next steps, clearly we need to look at the information that we've got. We need to build on the data that we've got because it's not a complete data set. And there is something also, as Phil alluded to, about actually taking this out to communities and just making sure that the information that we found actually resonates with their experience. And then I think ultimately what we would see is a bit of work to engage and work with our communities to develop solutions which are based on their needs and that are developed with our communities. So that's the sort of longer term plan.
Hi, I'll just introduce myself. I'm Julie Boyak. I'm the new voluntary sector rep to the Health
Good to
and
meet you, Julie.
Wellbeing Board. So hello to everybody. Just wanted to say it's an excellent report. I just wondered, we know that people with a disability are more disproportionately affected by COVID during COVID and continue to be badly affected, not only in terms of the health inequalities, access to services during COVID and post-COVID, but also loneliness and isolation. And I just wondered how that is going to be shown in the impact assessments that you're going to have within the communities as well, and hoping that you'll engage with the voluntary sector who have worked very hard during this period, as have our other colleagues as well.
I think that's a really useful comment, and that's something that we'll take away and look at. I think you're absolutely right. We as we get more into this and sort of get more into the detail, we will look at across the impacts of COVID on people with disabilities, but really across the whole kind of spectrum of communities, really. But I'll certainly take that away and ensure that we get that focus on disabilities and the impacts there. Absolutely, we will engage with the voluntary sector on this, because I think your intelligence and your, we can get the data, but we can enrich that data with your intelligence and knowledge of what's happening on the ground.
Thank you for that. Councillor Patterson.
Thank you, Chair. It's more really just in response to David's question. We do have a very active food poverty working group in the council, and we work very closely with Northumberland Communities Together, who are opening up quite a lot of hubs in the more deprived areas, so that residents can come in. Citizens Advice Bureau are there, so we're expanding that out to a lot of areas. We also have regular meetings with Dr. Sayers via the CCG. I would like to meet with more GPs from the more deprived areas, just to get some kind of snapshot exactly of what people are presenting with. But it's just to let you know that we are very, very much wanting to see what we can do about health inequalities in Northumberland. It's vitally important.
Okay, thank you for that. Yes.
Hello, my name is Pam Travis. Just to introduce you, I'm the Group Director for North for CNTW, the mental health provider, and mine's an offer, really. I think we've probably got information that would help you look at what's coming through in Northumberland, and I know that referrals to service aren't everything that we're seeing in the community, but it may be helpful if we can add to the report in the next steps. So just an offer of information.
Yeah, I think we'll gratefully take up that offer. Thank you.
Liz might have wanted to come in on that as well.
Yeah, I mean, it's sort of on the wider issue of inequalities, really, because that is a challenge which affects all of us on this board, and you know, clearly we can't. It's not something that we're going to be able to tackle effectively in isolation. I think Phil alluded to it earlier, that we're really keen to develop a Northumberland sort of whole system inequalities plan, and I think we'd like to put together an inequalities, or develop an inequalities summit next year to just provide a bit of a springboard to develop that, because as I said, we can't do any of that in isolation. We need to make sure that that plan is consistent with all of the other inequalities plans that are in development at the moment. There are a lot of groups which are focusing on inequalities, and we just need to bring all of that work together and develop a single plan for the county.
Councillor Sanderson.
Thank you very much. Liz has just covered the point I wanted to, but I'll be very briefly just expand on it slightly, which is that the administration has a plan that has got two basic remits. One is to positively encourage, motivate new business and support existing business. The other is to help those people who need our help the most. They're actually quite interlinked, because more employment obviously helps that. But Liz and I and Phil and others had a meeting some time ago, and Phil is now looking for a date, I think at the end of January, for this summit to take place. I want to get on with this long before we get to the end of this year. So he's well onto that, and it's very important that we all work together. What I would say is that I've found out a lot in the last month about how good the work that is being carried out now is, and how good the staff and how well they've done their part. I just feel, as someone who is not a professional in any way, that bringing everybody together to have this plan that will actually do something about inequalities rather than just talking about it, which politicians do, but often don't actually take that really important step to do something about it. To support all the really good work that's going on now, but to see if we can't work together even better going forward. So I'm really grateful to Liz and all the staff that I've met over the last few weeks, to Wendy Patterson, who's been extremely important in this, and to Phil, who's going to find this date and let us know what it is before Christmas. Thank you.
And then just the gentleman behind you, and then I'll come to my question.
Hi, Alistair Blair, Northumbria Healthcare Medical Director. I suppose it's 2 points. The first is an answer to some of the questions, and I'd agree entirely with Councillor Sanderson. If you look at the health inequalities, they're all directly related to two things particularly. One is the socio-economic basis, and the second is the educational achievement. And actually, unless we have an educated population and one which is socially economically thriving, you can't do an awful lot about the health inequalities, because they all predicate on those two factors. It's not to say we don't try, but those are by far the biggest drivers. So I think looking at those in the impact of COVID is probably a really rich vein. The second thing is that within the gift of healthcare, we've done quite a lot of work on the health inequalities, particularly, for example, on waiting lists and things like that. So there's a lot of work that's gone on, and if that would help to share, because I know you're one of your challenges within the report was for partner agencies to share things to make this report richer. More than happy to, because we've got some quite good articulated work that shows, for example, that we don't have inequalities in a waiting list, which could easily present, and that would be unfair. So there's quite a lot of work for our Health Inequalities Programme Board that I'm more than happy to kind of feed in to this, because it makes it a richer report, if that would help.
That would be most welcome, thank you.
Thanks, Chair. And just to add to that, as a trust, we've just launched our community promise a few months ago, very much looking at how do we move policy to ensure we support better local procurement, support better local communities. So I think this all links in with the summit that Liz was talking about earlier, and I think as a trust we'd be more than happy to get involved in.
Thank you. I welcome the summit. Already had some conversations at how important that would be. Really important to highlight inequalities and work towards theirs as a group of people in Northumberland. And I think if you take this report in isolation, it's easy to think that actually we're not a long way forwards on this already. So we've also got agenda items today on population health management, which is presented by Robin Hudson. That tells us more about what's going on to reach into the communities, thinking about thriving communities and how Northumberland communities together actually tells us more of the picture. And then we've got the presentation on the ICS and how that will inform how we work as a place within the commissioning arrangement. So there's parts of the jigsaw that need to fall into place, but it's our job to make sure they're all going in parallel so that we get the best start, I think.
Right, I'm just going to go to the recommendations. Recommendations in the first two bullets are to consider and comment on the document and to consider how partners and communities can contribute to a broader assessment. Now, we've had a good debate and good amount of comments on that, and they will be captured, and I'm sure they can be passed on to Phil to carry on with that. We've then got to agree to receive regular updates of this work. I'm taking as read that we do all agree that. Formally that's done, thank you. Okay, so what I'll do is, thanks for that Phil, is I'll move to item 5 on the agenda, which is Population Health Management Quarterly Update, and this is a presentation by Dr. Robin Hudson. Thank you, Robin. There's a clicker. Okay, and if you can turn your mic on, that'd be great. Fantastic, thank you.
Good morning. I spoke at this board meeting maybe the last time, just giving you really an understanding about population health management, and I don't want to go through all that yet again, but what I do want to do is give you an update about what we've been doing in terms of laying some foundational work down. And I'm delighted about the summit that's going to happen next year, and absolutely, certainly as a CCG, we're committed to supporting that and working with you in that. Right, okay, so the slide's just gone off. Okay. Right, okay, must be my fault, thank you. So you'll be aware of something called System Transformation Board, which is chaired by Sir Jim Mackey, and a couple of years ago they came up with the System Transformation Board, just agreed on 5 flagship programmes, really just to sort of hang a lot of the work that needs to take place. Obviously there's a lot of detail beneath those, but it's the key thing that I've been reflecting on is about us as statutory organisations, myself within the CCG, how do we lean into our communities and empower them and enable them to move this agenda forward themselves as well with our support? Something about this distributing power, distributing leadership to them. But a nice phrase we've been using in a lot of workshops has been, how do we lean into them and support them in the ways that they need? So there was a King's Fund paper done on leadership, and I invite you to read that if you like. I won't labour that point. However, in the last couple of years, we have been moving forward on a journey. We have had the System Transformation Board. We had a opportunity through NHS England to engage with the Optum programme, which gave us a little bit more of a understanding of the science and method behind population health management. And I chair a group called the Health Improvement Group, which has really been there to try keeping the conversation going between all our stakeholders, whether that's in healthcare, the local authority, the VCS. COVID has been a challenge, and the Health Improvement Group, we're trying to get that moving once more. Whether that's the right group to be moving this strategically forward, I'm open to suggestions from the leaders within the system. One success we have done is we agreed and released £1 million out of the system to help to support the population health management agenda. If you see the figure at the bottom, that's an artist drew that for us when we did a workshop. We did a workshop looking at harm in the 0 to 19s in Northumberland, and that picture just sort of shows and helps to map out the journey that the typical 16-year-old has been on since they were born, and the different factors that may be at play in where they are right now in their lives. So these flagship programs, we've held 2 workshops, and the purpose of the workshops really is just to see how we can bring the right stakeholders together, whether that be in the community, public health, general practice, the CCG, to see how we can start to map out what great work is taking place, because there is a lot of great work taking place, but then also starting to see, well, where are those gaps? Where is that unmet need? And how can we start to think about doing an intervention? We had a second workshop a few weeks ago looking at alcohol and health, again, bringing together licensing, addiction services, the VCS services, and actually general practice, to see how we can start linking up between what's going on in healthcare and what's going on in our local communities. Our workforces are really essential here, and I know that lots of organisations are looking at health inequalities, looking at population health, and certainly we've been doing a lot of work, particularly with general practice, to see how we can skill them up, but also help them to start networking with their communities, because general practice can't just sit there in isolation doing its health thing without actually engaging with their local communities, and that's the next important piece of work. Underpinning all of that, we've had a lot of support from public health, and you might be interested, but Wansbeck Primary Care Network is already looking at the whole issue of child poverty, because it's been identified in their data that there was an issue there, and the Primary Care Network in Wansbeck wants to engage constructively with its partners to do something about that. The most exciting bit, just to sort of give you a summary of, is our work with the local community and with Northumberland communities together. We've had 3 events just last month all over the Northumberland, where we brought together the VCS with the CCG, local authority, public health, and we started to think about this banner, or this Thriving Together banner, something that we can grab onto. We know through COVID that our communities have stepped up, with community champions who've stepped up to help those individuals who are socially isolated. We know there's a lot of energy out there and a lot of creativity out there. And so to try and start that work and to support that work, we've done 2 things. One is we've commissioned with Citizens Advice a tool called Frontline, which is a digital tool which anybody can sign into, anybody doing anything in their community, whether that's men in sheds, whether that's food support, whether that's or walking groups, can actually sign up to it, and they can start referring people to one another in there. They can find out what's going on in their small area, and they can refer people backwards and forwards between themselves. It's also got a self-referral capacity as well, so people can actually sign up to things themselves online. The other thing that we've done is we've released £250,000 out of that £1 million that I talked about earlier, and that we're making that available to the voluntary sector, and we're going to ask them to bid, applying, and when they're in their bids, the emphasis is on about collaborative working. Who else are they working with in their area? And secondly, how are they going to address health inequalities and this whole agenda on inequalities? I talked about this the last time I spoke, and this is about a forum. This thing about the method of how are we going to change things? Well, I think one option which we are considering and testing out through our workshops
is of an academy or a forum where we can bring the right stakeholders together, get them to agree on what the problem is by looking at data, and then looking at ways to solve those problems with interventions. And that's all going to be underpinned with rigorous evaluation, so we know what we're doing. There's no point doing lots of things without really knowing what's happening, what the impact is going to be. And the biggest challenge that we've got here actually is about culture, and how we change our culture so that we can actually break down those barriers and open up those lines of communication, and all of us lean in together back into our communities to support them with this work. So that's the end of my presentation.
Very much for that, Robin. Do we have any questions or points to raise on the back of that report? I don't think we do, actually. You got off lightly. There we are. So thank you very much for that. Much appreciated that report. I'll go on to the next item on the agenda, which is an update on ICS. Discuss how Health and Wellbeing Board may link into the ICS Integrated Care Board and Local Place-Based Northumberland System Board, and a presentation by Mark Adams. As you're getting ready there, I guess you must be Mark. So
thank you very much indeed, Chair.
Thank you.
For anybody that doesn't know me, I'm Mark Adams. I'm the Chief Officer of Northumberland, North Tyneside, North Cumbria, Newcastle and Gateshead CCGs. And we have had previous discussions about the ICS development at this board. So this is to give you a little bit of an update on progress since then and where we've now got to. Bear with me till I get the right button. You sure it was that one, Robin? It wasn't just no. Pardon me. Is it that one? Lovely. Thanks very much indeed. So as members of the board will be aware, we have a very large ICS, integrated care system, that we're developing in this area. And that it covers North Cumbria and then Northumberland all the way down to Middlesbrough and the Tees Valley. And with the appointment of Professor Cillian Donaldson as the designate chair of our ICS, that has been one of the springboards for us now to move forward quite rapidly in terms of the development of the ICS. Noting that the processes of central government in the House of Parliament and Lords, etc., still have to be concluded, the expectation is still that we will have ICSs brought into being on the 1st of April next year. And two key elements of that will be the creation of an integrated care board, which is the statutory NHS board part of the ICS, and also an integrated care partnership. And I'll talk a little bit more about those further in the presentation. But part and parcel of that work has been Cillian's work to engage parties across the whole of the ICS area, not least local authority colleagues, but also far and wide across the NHS and also voluntary and community sector as well. In terms of local authority engagement, Liam has had one-to-one meetings with council leaders and executives, general wider meetings that he also held in July and August, etc. And those culminated in a set of joint management executive meetings that he has chaired, and there have been 4 of them to date, with local authority chief executives, NHS chief executives across the whole of the ICS to work on the development of the structure of the ICS. A lot of that focus has been on one of the key tasks of the ICS, which is to take on board the commissioning functions and responsibilities of the existing CCGs. I'm not going to go through the functions and responsibilities of the CCGs in great depth and detail. There's actually 247 statutory responsibilities of a CCG, but that slide gives you some indication of some of the key areas that CCGs currently undertake and will be expected to be picked up by the integrated care systems going forward. The CCGs, as I'm sure you're aware, we are statutory organisations. We have our own governance structures. Those structures include the governing bodies, the equivalents of boards, there are executive teams and management groups working in those organisations. And we have various statutory committees in much the way that many statutory organisations do. Our current spend in terms of all of the CCGs across the ICS area is somewhere in the region of 5.33 billion. And that slide gives you a fairly clear indication of where that money goes, where we spend money with our colleagues and our provider organisations across the ICS in order to provide services for the public and patients who we serve. You'll see that a large amount of that goes to the hospital sector. We have a large amount going to primary care, mental health services, etc. And other key elements that are split out in our budgets in terms of community health services, the costs of prescribing, and the running costs and other areas of the CCGs, which includes things like building and estates, etc. Work has gone on through those joint management executive groups that Salim has been leading to think about a high level ways of working and I guess a structure to our ways of working. These are not things that are now set in stone, and these are things that are still part and parcel of our discussion at the moment. But in general terms, the ICS will be engaged in those big strategic directions of travel, the big strategic priorities for us across all of our communities in the ICS, but also some of those things which we believe work best across that large footprint. So that includes things like workforce planning. So it makes no sense for us to have one part of the ICS doing quite well in terms of the availability of workforce and another part of the ICS doing less well. So it's for those kinds of reasons that those kinds of things may well get dealt with at a high level. Also things like health emergency planning and resilience, and of course that remains uppermost in our minds with everything that we continue to do in terms of fighting the challenge of COVID, but also the vaccination programs as well. And it is also very much going to hold a view about population health and reducing health inequalities across the whole of the ICS. Though we would fully expect to continue and very much want to continue that work at a place-based level for here in Northumberland, for instance, and obviously we've had those discussions earlier on in the agenda today, and we would hope that that would continue in terms of the public and patients of Northumberland. Pardon me. In terms of working at place, we very much want to continue to devolve down to a place-based level very many of the things that the CCGs already do. Monitoring quality of local health and care services, continuing primary care commissioning at a place-based level, and all the work that we do in terms of working with community partners, local authority partners, and everybody providing services at a place-based level close to our public and patients. It's also the case that we need to understand how this new organisation will continue to work with health and wellbeing boards, such as this one today, and continue to work with you all in terms of commissioning those services as close as we possibly can to our public and patients, and as close to the level that we provide those services for our public and patients. In terms of each of the different areas of the ICS, there are health and wellbeing boards, there are current local authority and health structures that allow us to do those things, and our hope and expectation is that we build on the strength that we currently have locally in order to be continuing to do that for our public and patients and do more for our public and patients. So again, I'm not going to go through the slide in detail, but you can see in all of the other areas in the ICS, there are similar structures to the ones that we work with and benefit from in Northumberland. In terms of governance for the place-based partnerships, our expectation is that the vast majority of the time in terms of developing the ICS will be putting in place the Integrated Care Board and putting in place the Integrated Care Partnership. We expect as we go into next year, so from the 1st of April, we will continue to work broadly in the way that we're working right now, if I'm honest. But it will be into next year that we will then start thinking about how we can continue to develop place-based working and use what we have already in place as a platform to continue to strengthen place-based working. The guidance, and one of those is on the screen there, gives us various different options to be able to consider that. So forums, committees of the ICB, etc., joint committees, local providers acting as lead providers, etc. I think those are all up for discussion for next year. But again, the thing that I would like to stress is what we want to do is to build on the strength that we already have in terms of our place-based working. In terms of thinking about getting into next year, Salim is very clear that we have three key objectives. One is to ensure that we get our transition completed from CCGs to the new ICB and the ICS by the 1st of April next year. That we have that new ICS, ICB and the Integrated Care Partnership in place, and we stabilise our ways of working. And I think the key thing for us here is not losing momentum in terms of all of the things that we are currently doing on a day-by-day basis to support our public patients. And then from June next year, we will go into a process of seeing then how we will now evolve to different ways of working in the future. And I think it's in that evolve area that we will then start talking about strengthening place-based working and building on what we already have. Just a little bit in terms of the governance, and some of this is about what is in the guidance, and some of this is about what has come out of those joint management executive meetings. The guidance itself gives us a very clear understanding of the direction of travel of ICSs and how they will work. There are expected to be 42, or there will be 42 integrated care boards working across the whole of England from the 1st of April next year. And the guidance gives very clear indication about the flexibilities of the ICB, which largely is about picking up the responsibilities of the current clinical commissioning groups. Sorry, before I move on, there are also key elements in the guidance about place-based partnership working, which I've already mentioned. I'm not going to go into any more detail on that one. But an important area is provider collaboratives and how our colleagues in our foundation trusts and our hospitals can and will come together and work together in a way that they just haven't been able to do up until this point in time. And I think that gives us some real opportunities in terms of thinking how services might be delivered more flexibly in the future across geographies, and how those organisations might support each other in terms of the delivery of those services. And I'm thinking particularly here in terms of everything that we're doing about recovery of services at the moment. In terms of the Integrated Care Board, there is a core membership that's set out in the guidance, and that has been one of the key areas of discussion that Salim has been having with local authority representatives and also NHS representatives in those joint management executive groups. There is now a core constitution. That core constitution is being considered by the CCGs in their public meetings across the whole of the ICS. And that constitution is now being sent to NHS England to consider. I think it's worth noting that it was not the responsibility and role of the CCGs to sign that off and agree it. It is the role of NHS England to sign that off and agree it. In terms of some of the governance features of the Integrated Care Board, it is a unitary board. So those on the board will have a very specific role in terms of bringing their personal knowledge, experience, skills, and everything that they bring for the roles that they currently do in their own organisations to that board to consider those big, wide strategic issues across the whole of the ICB. And this was referenced earlier in the meeting by David, that there are four key areas and purposes for the Integrated Care Board. So improving outcomes in the population of the whole of the ICS area, tackling inequalities, enhancing productivity and value for money, but also supporting the broader social and economic development across the whole of the ICS. In terms of the other key structure of the ICSs, those integrated care partnerships. And the integrated care partnerships, they will have a key role in setting the tone and the culture of the system, and also the operating and collective model for accountability and the accountability of the ICS, particularly in respect of local residents. The key requirements of the integrated care partnership will be to determine how the ICB operates, agree leadership arrangements, and also tasked with holding the ring on the strategy for the integrated care system across the whole of the area. In terms of the integrated care partnership membership, the chair will be jointly selected by the NHS and the local authority. It can be the same chair as the ICB, but that is yet to be determined. And members will include all local authorities and the local NHS as well. So it is a big and very wide partnership, bringing together a vast range of knowledge and experience, and also local understanding from the whole of the ICS. So the core members will be local authority and representatives from the NHS and the ICB, and there will be a chair and the vice chair. And then there are a range of other potential members as well, which cover a wide range of our voluntary and community sector colleagues. And we are still working through the process of what that might look like at the moment, and Liam is continuing that work with local authority and NHS representation. So in terms of proposing those arrangements, the action required for the ICP, as I said, we will need a chair in place. There will be a set of terms of reference and again, developing those formal agreements for engaging and embedding with VCSE colleagues at a systems-wide level. And it will also then work to create its own plan and an integrated care strategy building upon existing place-based plans across the whole of the system. In terms of next steps, the engagement requires for a draft constitution, and that draft constitution has now been completed and has been lodged with NHS England for the Integrated Care Board, but we will require similar documentation for the ICP going forward. We are awaiting feedback on the constitution from NHS England for approval, and that will be a key milestone for us as we work towards the 1st of April. Just a final couple of points. The first designate appointment to the Integrated Care Board has now been made, and there was a national process for recruitment to the chief executive roles of the ICBs across the whole of England. And we have now Samantha Allen, who is our designate chief executive officer, who is coming to us and will start with us on the 31st of January next year. Samantha is a Foundation Trust Chief Executive from the South Coast, from Mental Health Services. And again, we're delighted to be able to welcome Sam when she comes on board. It will be another real key part to putting in place our structures for the ICB, and again will give us a great degree of momentum in terms of working for the new year and the things that we need to do by the end of the 31st of March. So I will stop there, Chair. I'm very happy to answer questions.
Yes, thank you for that. I was at a meeting at Gateshead with all people from other authorities. I think there was a degree of scepticism from other authorities about this, but nonetheless, I'll invite questions. I've got Liz Morgan.
Thanks, Mark. That was really a really helpful update. I've got two questions for you. The first one is, do we have any more information about whether we're going to have just one ICP or more than one ICP? And then the second question is that, given that form should follow function, how much planning can we do about what our local place-based system board is going to look like?
So on the first issue about the ICP, the guidance tends to, or the guidance does indicate that the expectation is there will be one ICP for each integrated care system. I think the thing that is still being discussed with local authority colleagues, and there is another joint management executive meeting coming up towards the end of this month, which will focus on this, is there an option and is there an appetite to have sub-meetings, for want of a better way of putting it, which is closer to place, closer to our public patients, closer to our populations. So that's not yet fully confirmed and determined, and that'll be one of the key elements of that meeting coming up. But there is that opportunity to look at that. In terms of the further development of place itself, as I've said in the presentation, I expect much of that work will happen next year and possibly from June time on. But there is no reason whatsoever why we can't have those discussions locally about how we think that we would like it to look. And we've been having those conversations in the Transformation Board, with those which are chaired by Sir Jim Mackey. I think though it's fair to say those conversations are at an early stage. But there's no reason why we can't have those discussions and continue those discussions. And certainly the other areas across the ICS are also engaging in those discussions as well. I think what we would expect to see as we get into next year is from the ICB, from Sir Liam and from Sam Allen, we would expect to see what the ask is of place. And I think it's only when we get to that point that we will then be able to consider locally in those Transformation Board meetings about what our response is and how we would like to then work at place.
Just following on from Mark's point about the system board that we will require in Northumberland, it needs to be developed in parallel with what the Health and Wellbeing Board require it to be for the people of Northumberland. So it's not a transition in isolation of our system board. It's about what are the terms of reference in relation to health and wellbeing, and how does the Health and Wellbeing Board inform our system about what its health and other providers need to be doing for the people of Northumberland. So we have to just, we've been a bit stymied by having to wait for the final say on what our ICB looks like and what the ICP looks like, because we can't get too far ahead in terms of the governance at a system level if we don't quite know what our structure needs to be across the North East. But we've got to always bring it back to Northumberland for how we all work together in Northumberland. So Absolutely. This relationship between health and wellbeing and system, and how the Health and Wellbeing Board perceives the creation of our system board, is really important. So everybody's got to be involved in that discussion when we get around to have it, and that's the what we really want to happen.
Okay, anyone? Yes.
Thank you, Chair. Jane Lothian, Local Medical Committee. Thank you, Mark. That's a very helpful update. I think one of the things, I've really got sort of one question with two parts. One is, this is a vast organisation which looks very much like the old Region Plus. How are we going to be an organisation with a memory that avoids the problems that a lot of us in this room have seen several times around? And the second part of that question is, the vision is very, very great, but there's an awful lot of work that goes on, and I'm saying with the CCGs and, business as usual. And there's a great deal of, disquiet about the fact that it feels like there's a cliff on the 1st of April next year. What guarantee or reassurance can you give that business as usual, with all the bits that make the cogs turn day to day, will continue?
So that's a very large question.
Sorry.
with a number of different elements. I think, as colleagues will know, change is a relatively constant thing in the NHS, and structures do change on a relatively constant basis. But one of the things that we've learned from that is, whilst we're dealing with these big changes, we're also doing lots and lots of work behind the scenes to make sure that we lose as little momentum as we possibly can. And I think one of the key things for that is we rely on all of the work that our staff do, and we all do, and you all do, on a day-by-day basis, and continuing to do that to make sure that we lose as little momentum as we possibly can. The direction of travel has been set towards this large ICB, but I think that whilst we can't give guarantees, I think the thing that we rely on is the CCG staff aren't going anywhere. They will continue to be here. They will continue to be doing predominantly what they're doing right now on the 1st of April. And I think we focus on all of the work that we are doing at a place base close to our public and patients to make sure that we lose as little momentum as we possibly can while this new organisation comes into being. And I think that's the thing that we've got to focus on to make sure that we lose as little as we possibly can getting into the new organisation. The final thing I'll say is, whilst it is a new and a big organisation, one of the things that we're trying to focus on is the priorities of that new and big organisation in very many ways needs to be driven from place upwards rather than from the big organisation downwards. And I think it's in that way also that we try and preserve everything that we have at place and everything that we continue to do for our public and patients.
Thank you.
Wendy Patterson.
Thank you, Chair. Most of the questions I had have already been asked, Mark, but I wonder, are you able to come to each Health and Wellbeing Board from now until April and update us, because I do think we need to know more.
So we're very happy to commit to coming here and continuing to keep you updated, yes.
That's great, thank you. It's immense, this, really immense, and I just worry that we won't get it all sorted out by April the 1st.
Okay, any more questions or comments? No, okay, I think we can wrap that one up. Thank you very much, Mark, for your presentation.
Thank you, Chair.
We'll look forward to seeing how this progresses between now and April then. I'll go on to item 7 on the agenda, and it's an update on the epidemiology of COVID-19 outbreak prevention and control plan and vaccination programme. And I think I've got Jill O'Neill. Yeah, Jill O'Neill's joined us, and she'll be presenting alongside Liz. So.
Thank you. I was just going to go and get the cursed clicker.
That's right. And I'll let you introduce yourself, Jill, before you start, okay?
That's not me moving that, is that you moving that?
Okay.
Am I supposed to be pressing the top one?
It's like our Sky controls. And if you could just press your mic on, that's great, thank you.
Yeah. Morning everyone, thank you very much for inviting me today. So yeah, I'm Jill O'Neill and I'm Interim Deputy Director of Public Health working to Liz. It is going to be a bit of a double act because the slides that I tried to leave till the last minute to write yesterday are obviously slightly now out of date based on announcements yesterday evening, so bear with us on that. The first slide that you've got there, and hopefully it'll be shared within your packs as well, is England broken down into regions, and for a 7-day case rate at the minute, England is tracking at 469,000 per 100,000. Clearly that's going to go up over coming days and weeks as Omicron takes over from Delta, but everything that we're trying to put in place is inevitably, hopefully, going to be slowing that. Across the graph, from a colour perspective, the ones that have been increasing the most over the coming weeks has been southeast and southwest, showing greatest increases. The northeast is the dark blue line, and we are tracking lower to the lower end of our regions at 388 per 100,000 currently. So I know that's quite a lot of detail in there, but it just shows that we have been fluctuating quite a lot, but we're projected to be on the increase slightly. This is now the dashboard that is produced locally for Northumberland figures, and our latest data is 378 per 100,000 population. We have been on the decline, but there is a latest slight uptick in our rates. And the middle columns highlight within our ward areas at the moment in time, Prudhoe and Cramlington have got higher case rates, and we've got Ponteland with our lower ones. But please be minded to note that these go up and down really regularly and fluctuate quite significantly. The next slide is basically showing our case rates over a period of time from July 2020 up till November, where we're at currently December, and our projections into January. And it just highlights as well the changes of our removal of restrictions and such like that we've seen, and the correlation between our figures there. But the one that I just want to finish on from a data perspective is this is broken down by age bands for us. It is good to note that our over 75 cases remain low and is an area of concern for us. So we do monitor that closely. So it is positive that it remains in the lower end. The purple line, which is the highest one, is our under 25s. And there is a correlation there with our vaccination status. And when we drill down further into 0 to 25, it's actually our primary school ages that are now got higher case rates. And again, there is that link across to vaccination. So we are continuing to monitor all of that as closely as possible. And I know we will be covering vaccination update, which is very much a good news story for Northumberland. So the next ones that I want to go through is a couple of slides around our testing offer that we have across Northumberland. And I do feel that this is a very positive picture for us across Northumberland. There is a lot of offers and opportunities for take-up of testing. So this slide highlights our PCR testing availability. Approximately 50% of people go to testing sites to pick up their PCR kits. And we've got fixed sites in Berwick, Ashington, Blyth and Hexham. And then we've also got our regional testing site as well. We've currently got about 22% of people that have PCR testing come through postal routes. And then for our asymptomatic testing, which is the LFTs, we do have a national programme that we work for community care home residents and supported accommodation. And then we also have a universal offer that's available through our pharmacies for people to be able to pick up. And also schools continue to be able to provide LFT kits as well. We do have a number of challenges, and it'll be interesting to see whether or not this gets now picked up, but based on the national guidance that's come out yesterday. We have been awaiting for a long time now a national testing strategy, and that links with the funding that is offered for us to be able to continue to run these programmes. And there is a risk if we don't receive additional funding that the PCR capacity may have to be reduced for us, and that's not something that we're keen to have happen to us with the current situation. And then moving into our local tracing partnership, which is where we do our contact tracing. This is coordinated through NHS Test and Trace, which is now part of the UCSA, which is UK Health Security Agency. And we have a window of opportunity where anyone can upload their information within a 4-hour window if they want to do a digital journey, as it's referred to. And then from a local perspective, because we know it's really important to have a local voice and a local telephone number as much as possible to encourage engagement and take up, we have anyone who hasn't engaged with the national team, we talk to them after 24 hours, but also for our most disadvantaged communities hitting deciles IMD 1 and 2, then we pick up after a 4-hour window to be able to try and have that local conversation. And as we were talking about before, this is trying to delve into inequalities and people who might be less likely to understand the implications of a COVID positive test and how to make sure that they've got everything they need to self-isolate as safely as possible. So moving now on to Omicron and variants of concern, and I've just got a couple of slides here just to really, I suppose, explain why the fact that all viruses mutate over time and new variants emerge very regularly, but a variant is classified as of concern once there is evidence of a change that could lead to causing more harm. So whether that be because of transmissibility, severity of illness and such like. And what we're seeing is scientists working incredibly hard to understand the effect of the Omicron variant on that transmissibility, the antibody responses, the vaccine efficacy, and so on. And this is why there has been the additional extra cautious approach being been taken with Plan B coming into place just to slow that virus impact so that we can continue to understand Omicron in more detail. So as I say, at the point of writing these slides, then there was the announcements around obviously the big push around vaccine boosters and the second dose for 12 to 15-year-olds. But again, the face coverings being compulsory in shops and public transport. And then also the additional guidance within school settings as well. And then the travel restrictions were the other main announcement that came out. And people now travelling back into the UK must take tests before entering the country, as well as 2 days afterwards as well. Now, as I say, the next slide was an update on cases of Omicron, and at the time of writing this at the beginning of yesterday, there was over 400 cases in England. We are seeing a really high rate of increasing cases now, so that data is out of date, and that's where Liz will come in at the end of this slide set. But what we are doing, working very closely with our health protection teams, is that for any confirmed or highly probable case, they are managing that situation with an incident management team or an outbreak control team, and obviously any confirmed case is being asked to isolate as per national guidance, and the difference now is for close contacts. For any suspected highly probable case of Omicron, we're also asking people to isolate irrespective of age or vaccination status. And that's when we're also doing the fast tracking of PCR testing, going down to Porton Down to do the sequencing to see whether the contacts are indeed also Omicron cases. So as I say, there's a real tight management of that. And across the North East, we are seeing now a scattering of Omicron cases, and they're all being managed as tightly and as closely as possible, working closely with the DPHs and the health protection teams. So really just to finish off with the last two slides, the main points to take away for the board this morning is that we maintain our local health protection board and the updating of the local outbreak management plan as much as possible, keeping a very tight governance around that. We are tracking the case rates as we've highlighted, and we are anticipating that they may well go up, but it's all about that severity of illness that we're particularly interested in and the pressure that then puts on the NHS. The variant of concern at the moment in time is Omicron, but we still remain vigilant for any additional new ones. Funding is something that we have to consider, and whether or not we're going to receive additional contained outbreak management fundings going forward into the new year. We need to understand the offer and continued programme for testing, because that's been a main plank of our prevention programme, that proactive case finding, and all of that is linked to our workforce capacity, not only in UCSA in the health protection team, but very much in the local authority public health team as well. So they're all things that we need to understand more from a national perspective to be able to deploy at a local perspective. And then finally, our key messages, we make no apologies for these being very much the same messages that everyone has heard throughout. It is still the hands, face, space, fresh air, ventilation in enclosed spaces, PCR tests for any symptomatic people, regular asymptomatic testing to continue, and that take-up of the vaccination for flu as well as COVID, and the booster programme that is now being rolled out at pace. It is that consideration of others around face coverings in crowded places, and ultimately being kind, because there's still a lot of anxious people out there very, very worried about COVID. So I'll hand over to Liz for the most recent update.
Thank you. So obviously a large number of changes were announced yesterday, and I thought it would be useful to just go over the background to why that has transpired. So it has become very apparent that the Omicron variant is outcompeting the Delta variant, and that's a combination of increased transmissibility and immune evasion. We know from the figures that have been released, well, the latest figures that I've got, are that we have 568 confirmed cases of Omicron in the UK. That's an increase of 131 on the previous day. But we also know that that's the tip of the iceberg. You know, the actual real number of infections is likely to run into thousands. And if that figure is doubling every 2 to 3 days, then we can reach very large numbers very quickly. So if that is the reality, then the pressure on the NHS could be unsustainable very quickly, and that's the reason why these additional prevention measures have been put in place. I think the booster is really important because the recent evidence which is emerging from at least one of the manufacturers is that booster gives much higher protection against severe disease and transmission than having 2 doses alone. So, the further prevention measures that were introduced yesterday are really needed to slow down transmission. So we've got a little bit more time to boost as many people as we can and provide as many people as possible with that boosted immunity, which will obviously protect the vast majority from severe infection. The changes that were made yesterday, in a nutshell. So from Friday, face coverings are going to become mandated in most indoor venues, including places of worship, but not when it's impractical. So if you're in the gym or you're singing, you don't have to wear a face covering. From Monday, people are going to be encouraged to work from home if they can. And from Wednesday the 15th, subject to the legislation, or subject to parliamentary approval, we're going to introduce NHS COVID passes, which are going to be based on two COVID vaccines, of vaccine injections, or a negative LFT to access nightclubs, indoor unseated venues over 500 people, unseated outdoor venues over 4,000 people, and any venue over 10,000 people, of which we have very few, fortunately, in Northumberland. So that's a bit of a synopsis of where we are at the moment. Very happy to, well, Jill and I are very happy to answer any questions if anybody has any.
Thank you. Really good report. I suppose my question is, there's been a fantastic effort around the vaccinations, but it's just really a word of caution for the board. The figures are still slightly misleading in that we often hear that we've got 85% of the eligible population vaccinated. Most of Europe talks about the whole population being vaccinated, so actually we've only got 67% of the UK population vaccinated. So that's 1 in 3 not vaccinated. So my question really is, if we're talking about boosters, that's great, but that's already with people who've got a vaccine on board. There is still a significant number who don't have a vaccine at all, and I think we just need to really be cognizant of that, because we do sometimes give a falsely positive picture of our vaccination rates as a country because we're alone in only including the eligible population rather than the whole population, which is what everybody else in Europe's doing.
Okay, Liz?
Yeah, I mean, I think that's a really good point because some of the figures that we were given at the Health Protection Board are that we have our unvaccinated population, so that's over 12s with no first dose, is about 32,000, and our over 18s with no first dose is 22,000. So that's still a significant number of people in Northumberland who are actually entitled to a first dose who haven't had one. And that's, you know, that's an area of activity that we're just continuing to focus on.
Okay. Any other? Yes.
I just wondered, in terms of prevention and the vaccination programme, are you able to offer vaccinations at home for those who can't easily get out?
I think.
Right. Okay. Thank you.
I've got a couple of questions. First one is about the boosters to 18 to 40-year-olds. It seems to have taken an extraordinarily long time, and I'm towards the upper end of that, so I've quite invested interest. It seems to take an awful long time from the announcement a couple of weeks ago that would be eligible, and the gap would be down from, is it 5 months to 3 months? And yet I still sit here today. I still can't book a booster vaccine, but I think I can on Monday. So that was my first question. Is that the case, and are we going to be able to do that fairly shortly? And my second question was about, it might be more of a question for Phil Soderquist if he was here, would be about vaccine passports, and in particular those who haven't had any vaccine for whatever reason they chose not to, who might wish to attend a nightclub or similar venue, and I see that you'd need a LCR test before going in. When would that happen? Would that happen a day before? Would there be a queue down the main street in Alnwick outside the nightclub with people doing that? How would that work? Because I have slight concerns about that. People after a few drinks being told they can't go in a venue because they're not boosted, or their phone stopped working, or some other thing. So how would those non-vaccinated people be dealt with in terms of them entering venues? Do we know?
So no, we don't know, because we haven't had the guidance for England, but obviously other devolved administrations have been doing it for a while, and I know that the government has been planning for Plan B. So one hopes that guidance will be available shortly. In terms of the vaccination programme and the extension of the booster, I think there's quite a lot that needs to be changed in order to extend that programme. So all the systems need to be changed, the national booking system needs to be changed, and there's quite a lot of logistic planning that needs to go on as well, because we're talking about, I don't know, something like 130,000 additional people who are going to have a vaccine in Northumberland. So that is a huge amount of pressure on the system. So I think that's probably where the lag comes from. But maybe Graham, who actually delivers the vaccination programme, might be able to give us a bit more insight.
I think I'm going to pass to Rachel, because I think she was going to give us an update on the vaccine programme anyway. So rather than me try to answer, if you give us your best picture of that first, that would help.
I'll take this off. Thank you. Yeah, no, I think the vaccination programme is probably at its most complicated point since it started, but I'll try and explain where we are up to, and I'm going to hope very hard that this button works. Oh, no. Great. It's not a very happy little button, is it, today? Ah, brilliant. That's great. Thank you. So, amazingly, yesterday was the anniversary of the very first vaccine to be given in England, and our anniversary in Northumberland is on the 15th of December. Since this vaccination programme started in England, there's been 99.8 million doses of COVID given, and in Northumberland, 635,139 doses of the vaccine. So then, just broken down for you, that's about 1,740 jabs every day, 72 jabs an hour, and 1 jab every 49.6 seconds, which is absolutely phenomenal. And the bulk of those vaccinations have absolutely been taking place in primary care, and this is all additional work, and they have delivered an amazing programme for us in Northumberland. Our performance is very strong, and we have the highest percentage uptake in England as an upper local authority area for both first and second doses, and we're currently within the top 10 for the boosters or the third doses in England, and you can see our percentages there at the bottom. So it is a very strong performance in Northumberland. This is a bit of a breakdown for you from a point of view of age for first, second and third doses in the blue columns, and versus the sort of England average. 10.4% more of Northumberland's under 50 population have received 2 doses than the national average, compared to 5% more over 50s. So it's the uptake really amongst our younger people and working age adults that really sets us apart from the rest of the country, because the older people were very much keener to come forward for their vaccine. So that sets us apart really. The vaccination programme for children and young people started in late September, and this was for a first dose for healthy 12 to 15-year-olds. This was done alongside the wider offer to 16 and 17-year-olds for a first dose, and the vulnerable 12 to 15-year-olds who then were given a second dose, and that was pretty much delivered in primary care. We've had a really good high uptake in these cohorts compared to regional and national averages, and the numbers are continuing to grow, and we're continuing to mop up those children. Most recent guidance has now said that that particular age group will go forward and have a second dose, and that can be 12 weeks apart. And 16 to 17-year-olds are currently being invited for their second doses as they become eligible via sort of local and national booking systems. Plans are being developed to deliver second doses to the 12 to 15-year-olds, and we probably have learned from the first time round, and we're going to look at a bit of a hybrid approach. So we'll do that in schools as well as use the national booking system. Some primary care networks, therefore, will be able to offer that as well as pharmacy sites. And we haven't heard yet about 5 to 11-year-olds, and that will be sitting with the various committees and scientific advice to say whether we will or will not be vaccinating that group. So we're still waiting for that. From a point of view of where we're up to with the COVID booster, the booster programme started in late September, and this was originally to deliver to our most vulnerable groups in cohorts 1 to 9 to provide that maximum protection. We're using Pfizer and Moderna as the vaccine, and it's preferred to be delivered no sooner than 6 months after the second dose for a patient. The booster can be co-administered with flu, and that has been what has tended to happen. And obviously primary care have been busy with flu for quite some time, but the co-administration is certainly helpful for patients where possible. And phase 3 has also included the third dose for the severely immunosuppressed individuals. So 128,257 third and booster doses have been delivered to date for Northumberland residents, and nationally reported uptake of 43.5% of the population, which is from 12 plus. 60% of those currently in scope for the booster programme are within that 40 plus age group, and 78% of those are currently eligible because they're at the right stage of the 6 months post second dose. So where we are now is, I think probably the programme is at its absolutely most complex point because of the combination of the priority cohorts, the different intervals and the different points of delivery. So we have quite a number of places now that you can have vaccines. There's been the single biggest expansion and acceleration of the programme, as we've just discussed, because of the emergence of the Omicron variant. JCVI have recommended extension to the booster programme to all adults now over the age of 18. The UK government is targeting the offer for all adults a booster by the end of January, which is really increasing the pace of the programme. And the booster doses for the severely immunosuppressed patients also recommended now 8 weeks after the third primary dose. As of the 8th of December, boosters are now available and are being offered no sooner than 3 months, so the gap in between has been shortened after the second dose, and that's been offered to cohorts 1 to 10. And the booster offer to cohort 11, which is your 30 to 39-year-olds, and cohort 12, which is your 18 to 29-year-olds, will follow, and will get invitations, will be announced nationally, no doubt shortly. Additional capacity has been made available across all delivery models to enable this expansion and acceleration of the programme, but that is also quite a challenge with our very tired vaccination teams now who have been doing this for a year. So we are looking to see if there's more community pharmacies that would like to help, and very much trying to work as a system in a very collaborative way to just keep the momentum up. But it does still there is still a huge amount of work to to be done in this very nationally controlled model with a lot of responsibility for the local delivery, which is quite a challenge at times. So thank you very much. I'm not sure that that really answered your question, Chair, about why you haven't been offered, but there is often a bit of a disconnect with what nationally gets offered to when the slots get opened up on the national booking system, and not all our sites are on that national booking system. So then the GPs do it when they are able to offer the appointments, and then this is all dependent on the supply of the vaccine that is there for them to put the appointments on, so it is quite complicated.
I think your second last bullet point kind of steers me in the right direction, shall we say. Right, questions both on that and on the first one, because we seem to move seamlessly from one to the other. Are there any more questions or points to raise? I think we might have reached the end of it anyway. So thank you very much for all of that. Well, interesting is probably the wrong word, but a significant few days coming forwards in the next few weeks. But so there we are. Thank you very much then. I'll go on to point 8, which is a forward plan, page 83 to 90. That's just to note. Our next and urgent business. I have no urgent business, and the date of the next meeting is in the new year, Thursday the 13th of January at 10 o'clock here. Maybe it's here. Maybe the rules have changed by then in terms of virtual meetings. We'll have some clarity on that in the coming days. So thank you very much. And Glenn has something to say?
Well, could I just say how grateful we are for everyone giving up their time to come to this meeting this morning. It makes it so much more valuable when we've got so many partners here. So I hope we can carry on like this and you know, bring collective thinking like we have today. So thank you very much to all of them.
Absolutely, and we'll look forward to further details on the summit coming up as well, because it's been very warmly received, as I've noticed in the room. So with that, I'll close the meeting and thank you very much all for your time.